been active in clinical lab diagnostics, particularly as an expert in TB for around 45 years. And she's going to be talking to us about leveraging the Cepheid GeneXpert platform for point-of-care testing. Thank you.
Thank you for the organizers for giving me the opportunity. I'm going to talk about the GeneXpert, but I hope I don't sound too much like an advertisement for Cepheid. I really want to try to be generic here. And this doesn't work. It's not moving forward, people. The assured protocol, but I'd like to point out that affordable and equipment-free are probably not possible, and we've just heard about CD4 point of cares, which certainly are not low cost and certainly are not equipment-free. So although lateral flow immunochromatographic assays such as for HIV antibody are available, they may not give the sensitivity and specificity, and for quantitative tests, they're not going to be helpful. So aside from assured, we also need an entire healthcare system, as Dr. Katzenstein had said, and our Dr. Thakkar also mentioned the right test ordered at the right time, in other words, near where the patient is, rapid reporting of results both to the caregiver and to the health system, so that we can get drugs to places where they need and so that we can pinpoint areas of additional resistance development. We want to deliver results that will change and improve patient management, because if physicians make decisions on patient care without the use of diagnostic, what is the point of having a diagnostic there? And we need to be able to act on the results, to have the resources and the materials there. And as everyone has mentioned, quality assurance and training are necessary. So the expert HIV viral load assay is not a point-of-care assay. You require a tube of blood. You have to centrifuge that tube of blood for 20 minutes. A centrifuge requires an infrastructure, electricity. Then you transfer the plasma to the cartridge, and the result is available in 86 minutes. Now, despite the fact that it's not a point-of-care test, it doesn't also need a giant central laboratory. It can be done in a smaller laboratory that has the necessary resources, and it will detect and quantify all the subtypes, group M, all the recombinants A through G, group N, and group O. Here are some results that were presented at the Union Against Lung Disease meeting last year from Dr. Leslie Scott from South Africa, who's been looking at this HIV viral load, and it's comparing it to the Abbott test, which is in the red, the Abbott real-time HIV, and also the Roche Cobas test, which is in the blue, and the green line is the Cepheid HIV viral load, and you can see that it tracks very nicely right between the results of copies per mil of those two very well-known and established assays. Here's another recently published multi-site clinical evaluation of the HIV viral load compared to the Abbott real-time, and you see very good correlation all along various viral loads from high to low. It goes up to the millions and down to about 40, and then detects but does not quantify lower. So I'm happy to announce today a brand new initiative from the Bill and Melinda Gates Foundation, where they have agreed to give Cepheid a grant to create a finger stick test for HIV viral load. So this is the test that you're hoping for. It does not require a spinning down of a blood. It's a whole blood test. It uses a micropipette such as shown here. Results will be available in less than 1 hour. We expect the accuracy at least to 500 copies per mil, so that will meet your standards of 1,000. And theoretically, it will run on the Omni instrument, which is pictured here, at remote sites. And I will talk just a bit more about the Omni in a moment, but this would be a battery-operated, independent instrument that could be, it's cheap, relatively inexpensive, and can be taken out in a car or in a motorcycle, and testing can be done on any GeneXpert test on this platform. So we have good background using a fingerstick test for HCV viral load. This is a report from an Australian collaborator, Dr. Applegate, who used a finger prick capillary blood interim on our HCV viral load system. And she is planning to use an even simpler result where the 100 microliters is collected, doesn't even go into a sample reagent, but goes directly into the cartridge. But her preliminary results showed very, very good results for finger prick capillary blood compared to venous plasma. And after correction, very good results compared to the Abbott M1000. So if we can do it with HCV, we should be able to do it for HIV. And we have also quite a bit of experience taking these tests out into the community on a mobile band, such as our TB testing done on the Tutu tester in Cape Town, South Africa. Patients accept it very well, and the results are the same kind of results that you would get from a central laboratory testing site. Now, one of the things that will be very important in the future is data accumulation from these far-reaching testing sites. And what we have developed at Cepheid is something called the C360, which is direct results sent to the cloud using a smartphone or a Wi-Fi system, so that every time a result is available on a GeneXpert anywhere, it goes to the cloud. The patient information is available only to the local users, but other information such as geographical location, percent positive tests, percent failures, results, etc., can be sent to public health. Here, Ministry of Health can look at it, authorized users of the data, Cepheid support in case there's a problem with the instrument. All the files from the instrument are available for the technical people to help troubleshoot. So here is an example of this system as a dashboard that was developed in South Africa for tuberculosis remote connectivity monitoring. And what you see is they've developed a system of red, green, and yellow stoplights for each testing location. They can look at reports by week. They can also look at machine failures. So if there's a particular site or even a particular user who isn't doing well, that person can be targeted for additional education. We know that with a TB test that a point of care rapid result leads to earlier initiation of treatment. And there are a number of studies from various countries summarized here showing anywhere from 1 day sooner treatment to 10 days sooner treatment just for TB in general. And one study from South Africa showing a month sooner time to appropriate treatment for rifampin-resistant TB, which you would expect because other methods of detecting rifampin-resistant require culture and a 30-day time period in general. And so what we see here is a 32-day earlier time to correct treatment. But having a 2-hour result still does not always lead to correct treatment. So in this study from South Africa, 15% of TB positive patients based on the GeneXpert result, even though the results were there in 2 hours, they were not treated immediately. Something failed in the system. Maybe the drugs weren't available, maybe the patient walked away during the 2 hours. And even more worrisome, many patients were treated who did not have tuberculosis. In fact, 2 patients were treated without TB for every actual TB patient. This is because physicians did not trust the results of the GeneXpert, and that's reasonable because the GeneXpert fails to identify somewhere around 30% of smear negative but actual TB positive patients. But back to point of care viral load, the WHO qualified 2 HIV detection point of care tests earlier this year. One of them is the ALIR-Q and the other one is the GeneXpert. And we were told that they Mike Ward, who leads the WHO's Essential Medicines Group, said, "These tests mark a significant breakthrough in our response to HIV, and as Dr. Katzenstein said, extremely important, particularly in children." So this is a test for either dried blood spot or whole blood using a micropipette, where the spot has to be lysed and treated in a warm thermomixer for 15 minutes, and then the liquid is placed into the cartridge, and the cartridge is tested on the machine. In the case of a micropipette, the blood is placed directly into the cartridge. Some sample reagent is also placed in the cartridge, and within 1.5 hours, the results are available. And the limitation of detection for this test is between 200 to 300 copies per mil for whole blood and 500 to 700 copies per mil for dried blood spot. It's not intended for monitoring. It's a qualitative test. All it says to you is positive or negative. And what you can see from the product insert compared to the Roche HIV qual is that the predicted positive agreement was 98.2%, and the negative predictive agreement was 98% for the whole blood, and it was 95.6% and 98.5% for the dried blood spot. So very good correlation of this test with a central multi-site type comparator that is well respected in the field. So the HIV qual study was presented by Dr. Louise Kuhn at the International AIDS Society, looking at infants being tested. 85% of results were delivered less than 3 hours. Most were negative, but a few were positive. She had 4.8% errors or invalids, but almost all of them on repeat test yielded a valid result. Specificity for negatives, 100%, and 8 of 10 positive results were confirmed. We're not sure about the other 2 that were not confirmed. The conclusion of her study was that ART can be started at a younger age than is feasible with conventional centralized laboratory testing. So here's a map of where all the gene experts are. There's more than 10,000 of them in the world now. More than actually 19 million TB tests have been run. And we think that just like the Ebola test, with the dashboards, you can see where they were run, and you can monitor performance of the Ebola test. The Omni platform is coming. It's closer to the assured requirements. Small, portable, less expensive, automatic connectivity to the cloud if it's available. We expect it to be available next year here in India. So the ultimate goal of point-of-care HIV testing is improved patient care and improved public health response. Any near patient location, infrastructure not necessary. Thank you.